Hello everyone, happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note whether the audio visual is all good. I believe the audio would be now better. Okay, all right. So happy evening, everyone. A very good evening, and I hope and I believe all of you are doing well. And I am sure that the audio video is now better. So here we are in the next episode of the Fast 5 clinical MCQs. We had one in the morning, and this is the next one. Let's try with this. Let me just see what happened with the pen tab. Just give me a minute. Yeah. All right, all good. So a quick update on what's going on the platform. So we have the ongoing Achievers batch for NEET PG 2023. The FMGE students can also make the best of it because we are doing the rapid revision, which will go on till mid-January, and then we will have IBQs and PYQs. And now the 4-month subscription is at approximately 13.7K, and using the code will give you additional 10% off as well. Okay, and we also have the various prof subscriptions, prof 1, prof 2 and prof 3 subscriptions, which are available for 1 month, 2 month and 3 months duration as well. Okay, so let's start with the first question. This is the first question, and please start answering. Amazing, that's great. So almost all of you, many of you have got this right. The correct answer is follicular lymphoma. The image itself is a giveaway because you see this follicle-like pattern. Right, there is this follicle-like pattern we have seen in the recent hematology class as well. So this is the follicular-like pattern. This is follicular lymphoma. Right, what is the other important clue here? CD10 positive in 70% of the cells, CD10 positive. So CD10 positive follicular lymphoma, FO is like 10, it is CD10 positive. Right, these are the major clues that are given here. CD19 positive in majority of the cells, that tells you that this is a B cell origin. Why is CD3 positive in 3%? Does it mean it's a T cell? No. So basically it is the normal T cells in the lymph node, and so only 3% showing the CD3 positive. Now if I ask you that what translocation you would expect in this patient, follicular follows 14 follows 18. 14 follows 18. It is translocation 14, 18. Translocation 14, 18 is what we see. It is BCL2 positive, and right, so basically on chromosome 18 we have this BCL2, which is anti-apoptotic, right, which is anti-apoptotic, so leads to malignancy. And remember that follicular lymphoma, indolent or aggressive? It is an indolent lymphoma which can present. You can see that even in this patient, the patient has come 2 months after he noticed a lump. That means it has an indolent course, and it can have a waxing waning type of course, right? The lymph nodes increase in size, the lymph nodes disappear, then the lymph nodes reappear. So the waxing waning type is what we see. Okay, the waxing waning type is what we see. So follicular lymphoma, BCL2 positive. Diffuse large B cell lymphoma, BCL6 also positive. Okay, it is BCL6 also positive, and it is more aggressive. Small lymphocytic lymphoma, SLL, which is CLL ka blood wala counterpart, CLL combined. It is going to be CD5 positive and CD23 positive. It is going to be both positive, CD5 and CD23 positive. So remember, for follicular, the keywords are, it is CD10 positive. Just a minute. So follicular lymphoma, CD10 positive, translocation 14-18, BCL2 positive, indolent course, waxing waning course, right? These are the important points. It's a B cell lymphoma. Mental cell, no, mental cell is CD5 positive, CD23 negative. Okay, mental cell is CD5 positive and CD23 negative. All right. So that was about this question. And what does this indicate? Kappa 70%, lambda 0%. So all the cells, like the majority of the cells, they have the kappa light chain. That means it is a one type of cell which is proliferating. So this indicates a clonal proliferation, right? A malignancy, a clonal proliferation is what it indicates, right? So that was the first question here. Let's go to the next question, an easy one. But you had a question based on this in NICT as well. Absolutely right. Easy one. This gives away the diagnosis. Burnt sugar odor. Burnt sugar is maple syrup. Okay, so you can remember as syrup is sugary, right? Syrup contains sugar. So maple syrup has sugar, burnt sugar or caramel odor. Okay, burnt sugar or caramel odor. So imagine there's a maple tree which has a lot of branches. This is a maple tree with a lot of branches. So here this is a defect in branch chain amino acids metabolism. The BCKD branch chain alpha keto acid dehydrogenase is what is deficient. So the branch chain keto acids increase. Okay, and there is a failure to thrive, neurological problems. All this is what we see in the patient. Which are the branch chain amino acids? Which amino acids should be restricted in this patients? In maple syrup urine disease patients, which amino acids should be restricted? The branch chain amino acids, because their metabolism is defective. So remember, when we are live, when we live, we branch out, right? So we branch out into various generations. So leucine, isoleucine and valine. Remember, the L is the leucine. Okay. Which vitamin supplementation should we give in these patients to improve the symptom? Branch chain keto acid dehydrogenase, similar to pyruvate dehydrogenase. It requires B1, B2, B3, B5, lipoic acid. Out of that, B1 is the most important. Thymine supplementation, very, very important. Okay, thymine supplementation is what can help in reducing the symptoms. Okay. So the supplementation, vitamin supplementation, thymine, amino acid restriction, live, leucine, isoleucine, valine, branch chain keto acid dehydrogenase. It is syrup, maple syrup has sugar or caramel odor. Okay, this is branch chain alpha keto acid dehydrogenase. Tell me that acid maltase. Where is acid maltase deficient? Acid is the lysosomal enzyme glycogen storage disorder. Which glycogen storage disorder is a lysosomal storage disorder? Pompey's disease. Pompey's disease, acid maltase. Carnitine palmitoyl transferase, CPT, is the rate limiting enzyme of fatty acid oxidation. CPT or CAT, carnitine acyl transferase, it is fatty acid oxidation. Debranching enzyme, ABCD. Cories is debranching. Okay, cories is debranching. So it is cories. Glucuronyl transferase, it is Gilbert, right? When the conjugation is not happening. So unconjugated hyperbilirubinemia, glucuronyl transferase is Gilbert. Okay, that is Gilbert. So that is about this question. Remember, the answer is branch chain alpha keto acid dehydrogenase. Okay. Going to the next question. This is a bit of a tricky question. Let me see how many of you get this right. Very good. Amazing. So many of you are getting this right. Absolutely right. It is decreased expression of class 1 MHC molecules. See, the question is, this study is likely to show that natural killer cells are particularly effective in destroying the malignant tumors with which of the following characteristics. So, what would be that characteristic of the malignant cells which will help in natural killer cell activation? That is the decreased expression of class 1 MHC molecules. Why is that so? Because the natural killer cells and the target cell. So if you see that even if the natural killer cell is binding to the target cell, but if the target cell has MHC class 1, this MHC class 1, it binds to the inhibitory receptor on the natural killer cell. It inhibits the activation of natural killer cell. So if there is MHC1 present on the target cell, then it is difficult for the natural killer cell to get activated. If there is no MHC class 1, then the binding will help in activation of the natural killer cell, and that releases the granules, right? The perforins, the granules, and these granules kill the target cell. So any cell which decreases the MHC expression, the MHC class 1 expression, that will be killed by natural killer cell. It helps in the activation of natural killer cell. Other example, viral infection. Natural killer cells important for viral infection as well, because even the viruses, they decrease the MHC expression. Even the viruses decrease the MHC expression, right? Clear with everyone the concept? So what you should remember that the class 1 MHC, it inhibits the natural killer cell activation. Okay, it inhibits the natural killer cell activation, the class 1 MHC molecules. Okay, so if you decrease the MHC1, the activation of natural killer cell would increase. Next question, let us go to the next question now. Question number 4. Which of the following would you think will confirm the most likely diagnosis? Endoscopic biopsy of the small intestine? No. Correct. Absolutely right. This is going to be, yes, Vikrant, Kiruba, correct. This is the sweat chloride test. Why? See, here we are not talking about the celiac disease or the gluten sensitive enteropathy, because this is just a 6-month-old girl, not even exposed to gluten yet, wheat yet, right? It's a 6-month-old girl, so we have to think of something congenital, correct? So 6-month-old girl is brought to her pediatrician because of increasing frequency of stools. The mother says it is smelly, right? Foul smelling. Loose stools that float in water, that means the density is less. What floats on water? Oil floats on water. So it tells you that it contains a lot of fat. That means there is steatorrhea. There is flatulence. There is fuzziness after feeding. Failure to pass meconium in the first 24 hours. Weight below 5th percentile. The stool is Goak negative, that is with the blood in the GIT, and cultures are also negative. So all this points to the diagnosis of cystic fibrosis. Okay, this points to the diagnosis of cystic fibrosis. So remember that cystic fibrosis, all the important points, meconium ileus is what we have. So cystic fibrosis, what is the gene affected? CFTR. What is the chromosome number? 7. What is the inheritance pattern? Autosomal recessive. What mutation? Delta F508, asked in the recent INI-CT exam. F for phenylalanine. Okay, phenylalanine at position 508 gets altered. Okay, so these are all the important points. What is the CFTR? Remember C for C, It is a chloride transporter, right? A chloride channel. So it is a chloride transporter. So what happens? There is increased sweat chloride, increased chloride in the sweat which is present. The secretions are all viscous, and that is why there is meconium ileus, inability to pass meconium in the first 24 hours, because all the secretions are very, very viscous. Okay, they cannot pass ahead. So the meconium does not pass. Why there is steatorrhea? The history of this floating stools, foul smelling stools. So whenever you have bulky foul smelling stools, think about steatorrhea. Okay, steatorrhea, because what happens, what is required for the lipid, the fat absorption, is also the pancreatic lipase. So in the pancreas, the secretions are very viscous. They are not able to come into the GIT. That is why the fat absorption will not happen. So there can be deficiency of which vitamins? Fat soluble vitamins. Vitamin A, D, E, K. Out of that, vitamin E is very, very important. Right. So that is why there is steatorrhea and there is failure to pass meconium. Now the stool qualitative fat analysis will only tell you whether there is steatorrhea or no steatorrhea. From the symptoms itself, we know that there's steatorrhea. So this will not confirm the diagnosis. Endoscopic biopsy of the small intestine. The small intestinal biopsy will have in the primary malabsorption disorders like celiac disease, वगैरह, where you see the villi atrophy, right? So this is not the celiac. The child is not even exposed to wheat yet. Ultrasound, X-ray will not confirm the diagnosis of cystic fibrosis. Sweat chloride test helps in confirming the diagnosis, right? So this is a diagnosis of cystic fibrosis. Okay, this is a diagnosis of cystic fibrosis, right? My next question to you is cystic fibrosis. It will have associated megacolon or microcolon. What does it have? Megacolon or microcolon? Yes, cystic fibrosis has megacolon or microcolon. No, remember that cystic fibrosis has microcolon. Megacolon is Hirschsprung's disease, right? A segment of the colon, mega, aganglionic. Right, this is aganglionic megacolon. It is Hirschsprung's. Cystic fibrosis is microcolon. Why? For the development of this colon, okay, this is the colon, this is the ileum. For the development of the colon during the antenatal time, the meconium should pass through the colon. Right, that stimulates the development of the colon. If there is no meconium entering the colon, if there is no meconium entering the colon will not be stimulated and it will not develop. And that is why, remember, it would have microcolon. Okay, it would have microcolon because the meconium is not passing because it is very, very viscous. Okay, meconium ileus. What is the X-ray appearance of meconium ileus? Anyone, what appearance is it called as? What is the terminology? What is the sign? Meconium ileus has what appearance? It has the soap bubble appearance on X-ray abdomen. Okay, the soap bubble appearance is what we see on X-ray abdomen. It is a soap bubble appearance, right? So that was about this question. Cystic fibrosis is important. Recent NICT had a question on that. Okay, recent NICT had a question on this. Going to the next question. So this is the last question. Really the fast 5. So quickly the time passes. Meconium ileus, ileal atresia is multiple bubble. Triple bubble is jejunal. Correct. Absolutely right. Amazing. This is medullary thyroid cancer. Why? What is the diagnosis? What are we seeing here? Which of the following is most likely to be also found? Second last line, VMA levels are increased, metanephrines are increased, epinephrine, norepinephrines increased. Whatever is given, the normal values are not given, but from the question I can gauge that it is increased. All these are metabolites of epinephrine, norepinephrine, which are increased in pheochromocytoma, right? So pheochromocytoma is a component of MEN2. Okay, it is a component of MEN2. And in MEN2, what tumor do we see? MED. MEN is medullary thyroid cancer. So it is medullary thyroid cancer. What other feature tells me it's pheochromocytoma? Headache, diaphoresis, palpitations. That basically tells me that it is pheochromocytoma. There is hypertension, high blood pressure, papillae edema, high blood pressure, papillae edema. Phentolamine improving the symptoms. So the anti-sympathetic drug improving the symptoms, right? And all these are increased. So pheochromocytoma, which is a tumor of adrenal cortex or adrenal medulla. Pheochromocytoma is a tumor of adrenal medulla, right? The catecholamines, they come from the adrenal medulla, which has a chromaffin cells which develops from the neural crest cells. Now the neural crest cell migration basically is controlled by the RET proto-oncogene. So when the RET loss of function happens, the RET gene does not function well. The NCC is not in control. So what condition do you get? When the RET, either you can have loss of function mutation, you can have gain of function mutation. The loss of function mutation is neural crest cell not migrating, so no ganglia. So there is aganglionic megacolon, there is going to be Hirschsprung's disease. Gain of function mutation, a lot of neural crest cell migration. So the neural crest cell tumors like pheochromocytoma, right? What else in the thyroid? The parafollicular C cells, again the I9CT question, neural crest cell derivatives, right? So parafollicular C cells are also neural crest cell derivative, and the tumor of parafollicular C cells is medullary thyroid cancer. What is the tumor marker for medullary thyroid cancer? It is calcitonin, right? The parafollicular C cells secrete calcitonin. So that is why the tumor associated is MTC from the parafollicular C cells which arise from the NCC. And MEN2A has parathyroid hyperplasia, right? It has parathyroid hyperplasia. Insulinoma, the pancreatic one, is a feature of MEN1. Remember in MEN1 we have pituitary, parathyroid, pancreas, right? We have 3 P's. Medullary MEN2 is 2P plus 1M. That is the 2 P's is the parathyroid and pheochromocytoma, and 1M is the medullary. Pancreatic adenocarcinoma with syndrome, like the Peutz-Jeghers syndrome, we have pancreatic adenocarcinoma, correct? Papillary thyroid carcinoma is post-radiation, correct? And pituitary adenoma, we have gastrinoma garima, which is the most common. Basically, the pancreatic neuroendocrine tumors occur in MEN1. Out of that, gastrinoma is very common, but there can be insulinoma also. Okay, there can be insulinoma also. And pituitary adenoma again is MEN1. So the answer here is medullary thyroid cancer. Is this clear with everyone? Right? So let us quickly see the 5 questions that we have discussed today. So what we have seen is, first one, the image is itself for giving away the diagnosis. Follicular arrangement is follicular lymphoma. It is CD10 positive, right? Remember that it is CD10 positive, BCL2 positive, translocation 14-18, indolent cause, waxing waning cause is what we have. Next we had burnt sugar is maple syrup, which is branch chain alpha ketoacid dehydrogenase, amino acids leucine, isoleucine valine, vitamin supplementation, B1 supplementation. Next, natural killer cells will kill the cancer cells if they have decreased expression of class 1 MHC, because decreased expression of class 1 means the NK activation will increase. The NK activation will be increasing. And then we have 6-month-old with steatorrhea, floating stools, bulky stools, foul-smelling stools, and there is failure to pass meconium because of the increased viscosity, cystic fibrosis. Sweat chloride test will help in diagnosis. Next, headache, diaphoresis, palpitations, hypertension relieved by phenethylamine and catecholamine metabolites are increased in the urine. So this is pheochromocytoma seen in men too, where we have medullary thyroid cancer as well. Okay, because this is the NCC related, the RET gene related. Here it is the gain of function mutation in the MEN syndrome. Okay, so that was about the first 5 classes. Will be sometimes on the Unacademy NEET PG Live, sometimes here and sometimes on the app as well. You will keep getting the updates on the Telegram group. Okay, you will keep getting the updates on the Telegram group. Dr. Shri, any tip on remembering the microscopic images? Get confused? Have a folder where you keep in your phone, where you keep the microscopic images all at one place. Whenever you are bored, taking a break, just keep revising them. The more you see them, the more you would become familiar with them. Okay? All right. Thank you so much, everyone, and goodbye. Take care and keep studying, keep revising, and keep winning. Thank you.